चालेल ना.
नाही
मी बारीक कधी सांगते. हॅलो.
ते काय म्हटलं का मी
हा. हो आलाय की. मी तर सुद्धा चालू आहे ती माझी मीटिंग चालू आहे ऑनलाईन. भैया आहे की घरात फोन आहे बघा. नाही पप्पा दुपारी आले भैया.
का फोन करले पप्पा
तेच की काय तर कामाचं विचारायला असेल. काय विषय आहे हे पण मला माहित नाही.
चालू आहे तुम्ही जातो माईक पण चालू आहे त्यांना विचारा पीपीटी दिसते
वगैरे पण आहे
काय सर हे?
दिसते मॅडम विचारा
मैम मैम मेरी पीपीटी विजिबल है?
हॅलो.
हेलो मैम.
हा सध्या तुम्ही विजिबल आहात. ओके. तुमची पीपीटी पण विजिबल आहे. ओके.
ओके मैम एम आई ऑडिबल?
या ऑफकोर्स.
काय झालं
So good afternoon to all. Am I audible? Am I audible?
यस मैम.
Okay. So let's start. Welcome to all on behalf of University of Health Sciences Nashik. I am Dr. Karli Gitanjali, Professor and Head of Ayush Department, and we are running things since 2 years. And today we are discussing gastroesophageal reflux disease. This is our second case of GERD, and we have Dr. Minal Gupta, PG scholar from CSMSS Ayurved Mahavidyalay, Kanchanwadi. Then in expert team, we have Dr. Pratibha Sonone. She is Associate Professor from Department of Gastroenterology or Department of Medicine from MPGI, Medical College, Nashik. Then Dr. Megha Surose, Associate Professor from Department of Panchakarma from CSMSS Ayurved College, Kanchanwadi, Sambhajinagar. And Dr. Manisha Shinde, she is Professor and Head of Department of Homeopathy Practices from the Dhanvantari Medical College, Nashik. So, welcome to all. Now start from Dr. Meenal. Please discuss your case.
Okay. Good evening, everyone. Myself, Dr. Meenal Gupta. I am a pre-MD student of Panchakarma from CSMSS Ayurved Mahavidyalaya and Rugnalaya. Today, I am going to present one of my case study of my patient who is suffering from gastroesophageal reflux disease. We will discuss this case in detail after a while. First, we will see what is GERD. As we all know, gastroesophageal reflux disease is a chronic gastrointestinal disorder that develops when there is a retrograde flow of stomach content back into the esophagus. Now, I am going to discuss about the particular of my patient. Patient description. My patient name is XYZ. OPD number is 1267. IPD number is 546. Bed number is 4. She is 34-year-old female. Her marital status is married. Occupation, she is an employee in IT sector. Her chief complaints are, my patient is suffering from acid regurgitation from 5 months, experiencing heartburn from 1 month, headache from 1 month, and from past 5 days, she is experiencing rash all over her body. Case history. A 34-year-old woman arrived at hospital. The patient claimed to have had complaint of heartburn, regurgitation of acid, headache for at least 5 months. Patient usually take medication like antacid, tablet, and syrup. But whenever she misses her medication dosage, she suffered from same symptom. Now from past 5 days, she is experiencing rash all over her body. She has no any complaint of dysphagia, nausea, vomiting, blood loss, or blood tinted vomitus, or sudden weight loss. She does not have any history of chronic disease or any chronic medication. Patient does not have any surgical history. She has no family history of disease like gastroesophageal, gastrointestinal cancer, etc. Patient don't have habit of smoking or alcohol consumption. But patient usually does work in night shift and has habit of having spicy and oily food in large quantity at unusual time, which contribute more for gastric acid secretion and causes gastroesophageal reflux disease. In physical examination, I have checked the following vitals in my patient. Her blood pressure is 130 by 80 mm of Hg. Pulse is 80 per minute and in a regular rhythm. Respiration rate is 18 per minute. Her height is 154 centimeter. Weight is 58 kg. And BMI is 24.5 kg per meter square. Nourishment, no any nutritional deficiency were seen. Body build is proportionate. In eyes examination, no sign of icterus and pallor. Skin, reddish patchy discoloration. No sign of ulcer were seen. Decubitus are normal. Nails, no sign of discoloration like pallor, icterus, cyanosis, no sign of clubbing, etc. In lymph gland examination, no sign of lymphadenopathy. Throat and tonsils examination. In visual examination of throat and tonsil, there were no sign of inflammation, swelling, redness, and any white or yellow patches. The patient may experience sore throat at the time of acid reflux. Micturition. Frequency of micturition is 3 to 4 times per day. No complaint of burning micturition, dysuria, or oliguria. Bowel habit. Frequency once a day. Patient is have constipation and hard stool consistency. In systemic examination, first I have done the oral examination. In visual examination of mouth, there were no sign of oral ulcer, bleeding gum, no sign of any pain, infection, and teeth loss. Lips, no cracked lips or discoloration of lips, teeth, though no discoloration and structural abnormality were seen. Tongue, there were no sign of any lesion or ulceration. Patient have white coating over the tongue. In abdominal examination is done as per the 9 quadrant of the abdomen. First, I have done the inspection. Skin over the abdomen is no, there were no discoloration. Shape of the abdomen is normal and no distension. No dilated veins are seen. No visible peristalsis. Umbilicus is inverted and there were no bulging. In palpation, per abdomen palpation is soft. Slight tenderness at epigastric region. There is no sign of rigidity and tenderness. Liver, no hepatomegaly, and in spleen, there were no splenomegaly. In percussion, dull resonance in epigastric region, and in auscultation, normal bowel sound were heard. In differential diagnosis, GERD, the cardinal symptoms are heartburn, regurgitation of gastric content, mild non-cardiac chest pain, and abdominal pain, headache. We can differentiate it with the coronary heart disease, which is having the cardinal symptom of chest pain, which more feel like pressure, tightness, or squeezing, which is often radiating to the left arm or shoulder. We can also differentiate it with the peptic ulcer disease, having the cardinal symptom of epigastric pain, nausea, and vomiting. Pain aggravate in empty stomach condition. In eclasia, cardinal symptoms are dysphagia, chest pain, and regurgitation of undigested food. The other differential diagnosis, there are gastrointestinal malignancy. The cardinal symptoms seen are eating difficulty, weight loss, and vomiting. In gallbladder disease, like cholelithiasis, cardinal symptoms are pain at right hypochondrium, which radiate toward the scapular region, nausea, and vomiting after eating the fatty food. After this, we go for investigation. In this, first is endoscopy. The indication of endoscopy in patient with gastroesophageal reflux disease are first is GERD symptom that are persistent and progressive despite appropriate medical treatment. And second one is dysphagia, persisting vomiting for 7 to 10 days. Third is involuntary weight loss. Fourth is evidence of GI bleed and anemia. Last one is finding of mass, stricture, or ulcer on imaging studies. This is according to the American Society for Gastrointestinal Endoscopy. In my patient, the present symptom of GERD do not indicate an immediate need of endoscopy. If the symptom escalate in severity, an endoscopy will be considered for further evaluation. Second, I have gone for hematological investigation. In this CBC, we are done. Gastroesophageal reflux disease can cause a chronic blood loss, which lead to anemia. Inflammatory assessment were done. In this hematological test help us to assess the level of inflammation in the body. Other tests like pH monitoring of gastric juice, we also done this. After all this investigation, examination, I have concluded the diagnosis of this patient is gastroesophageal reflux disease. Thank you.
Thank you so much, Pratibha, for the Meenal, for detailed explanation about case GERD. Now, we have Dr. Pratibha Sonone, who is Associate Professor from Department of Medicine, Gastroenterology, and she is from MPGI Government Medical College, Nashik. Dr. Pratibha.
Yeah. Hello, madam.
Yes, ma'am. You are in traveling. Okay.
Yes. This is interesting case of gastroesophageal reflux disease. Now she has a few risk factor like irregular eating habits, eating excessive meal, and eating spicy food. Okay. But in general, in patients of gastroesophageal reflux disease, we have many other risk factor which should also be considered. So I will just elaborate for the discussion purpose. like patient who are obese, patients who are on medications like ecosprin or clopidogrel for their cardiac conditions. Then patients who have disturbed lifestyle like irregular eating habits, lack of sleep. Then patients who are smokers, those who are alcoholics, they tend to have more reflux. So these are the risk factor, and again a male gender is a risk factor. In addition to that, uh, when we do an endoscopy, there can be some pathological reasons for this gastroesophageal reflux disease. Like there can be an hiatus hernia, there can be a loose lower esophageal sphincter, which predisposes to the reflux of the acid into the esophagus. Hello?
Yes, ma'am. Please continue.
So GERD is actually basically of two types, that is non-erosive reflux disease and erosive reflux disease. So 80% of the patients are non-erosive reflux disease. That means their endoscopy is normal and they have symptoms of GERD. So such a patient, they usually respond well to the medication and lifestyle modification. 20% of the patients have erosive reflux disease. That is, they have ulcerations or erythema in their lower esophagus. That is called as a erosive reflux disease. Now, these are the patients who have more trouble. They are more difficult to manage with the medication. Out of these patients, few patients may develop complications of gastroesophageal reflux disease. So, what are the complications? On long standing GERD, patients can develop strictures in the lower esophagus. Sometimes they may bleed because of the ulceration. Chances of upper GI bleeding is always there. And the severe complication is Barrett's esophagus, that is a pre-malignant condition which can progress to the adenocarcinoma of the esophagus. Less than 1% can develop adenoCA also. So this long-standing acid exposure of the lower half of the esophagus leads to the increased chances of malignancy. So that is the most serious but rare complication. Okay. Now, depending on symptomatology, we have to treat the patient first with medicine. Second, lifestyle modification is always necessary. The most important lifestyle modification required is having small frequent meals. There should be a gap of 1 to 2 hours between meal and their sleep time. They should avoid excess of tea, coffee, alcohol. They should avoid wearing tight jeans or tight clothes around the abdomen. If they are obese, they should try to lose some weight because that is aggravating factor. So all these lifestyle modification in addition to medicine will help the patient. Now, in some subset of patients, still patient may remain symptomatic. So these are the patients who have some functional component. So they may be under some stress or they may have some motility problem. So these two kinds of patients are actually difficult to treat patients because their symptoms persist despite of giving them treatment.
Okay. Okay.
So if there are any questions, we can discuss.
Okay, ma'am. Later we will discuss. If anybody is having question, please note down. We will discuss later. Now, thank you so much, ma'am, for your time. You are traveling, but you gave us time. Thank you so much. Now we have Dr. Megha Suravse from CSMSS Ayurved College, Kanchanwadi, Sambhajinagar.
Good evening, one and all. Okay, thank you, madam. Thank you, Carly, madam, Department of Ayush, for giving me the opportunity to have the expert talk in the online clinical meeting of GERD. Yes, we in our Ayurveda Shastra, we call it as a part of Ajirna. To be more precise, it is Amlapitta. To be very more precise, according to this case report, it is Urdhva Amlapitta. So today we are going to discuss regarding it. We'll see that what Ayurveda Shastra talks regarding it or what are its views. So when we see that all the classical descriptions of Amla Pitta, it emphasizes that pathophysiological condition. Amla Pitta is nothing but it is a pathophysiological condition in which Pitta is vitiated, म्हणजे प्रकोपित होणं. Because of the Dravaguna, and because of that thing, there is creation of soreness, or we call it as Amlata, to the food what the patient has eaten. Okay, so the terminology called as Amla Pitta. Now, what is the Ayurvedic concept? I'll try to tell you that actually it comes under the concept of Ajirna. Yeah, of course, the person from the Ayurveda dome, they will understand that this concept is given in the Grahani Adhyaya by the Bruhat Rais. And a very elaborate description has been given by Kashyap Samhita, Madhav Nidana, Bhav Prakasha, and so on. So the main thing is like why it happens. That is a very important question. The answer to it is like the people do not follow the code of dietetics given in the Ayurveda Shastra. So what are the code of dietetics? It is, we call it as Ahara Vidhi Vidhana, that is eating principles. It is not a very big deal, only 10 points given in this that you should eat which is hot, which is unctus. You have to eat only when the previous food is digested in the proper quantity. You should not eat the food with the opposite potencies. And you should, whenever you eat in a pleasant environment, not too fast, not too slow, eat mindfully without talking or laughing, and eat after considering your body status and your digestion power. In addition to it, they are talking about Ahara Vidhi Visheshayatana. That is, what are the factors very necessary. So whenever we are eating any food, nature of the food is necessary, whether it is heavy or light or hot or cold, whether the food is processed in a very good manner. It is, if the process, like if you're taking buttermilk, whether it is churned in a very proper manner. The quantity of the food we are eating is another thing. Combinations, which combinations I am eating, that is also very important thing. Geographical origin of the food is important, because we see that coconut oil is used in Kerala. Then sarso ka tel is used in the northern side. We use groundnut oil. And if I start using the sarsa oil, it will be not beneficial for my GI tract. So geographical origin also very important. Then time of consumption is also very important. This will be like according to season, age, and condition. You have to follow the dietetic rules and the habit of individual. Habit of individual, that means what? If the person is having the habit of taking non-vegetarian diet right from the childhood, and after a person getting married and her in-laws in taking the vegetarian diet, then automatically she switched on to the vegetable diet. So this creates the crisis in the body. Okay, so that thing also you have to keep in mind, that what type of the habit of food taking you are having. So these all important things, it comes in the code of dietetics told in the Shastra. To be very particular about the Amla Pitta, what are the causes of it? Causes, like it depends on the types of ahara. That is, some persons keeps on taking. Whenever they feel hungry, they'll take only poha. They'll be taking only kulatta. They'll be taking the husky food only. So types of the ahara. Ultimately, it will create the alteration in the metabolism. Amla Pitta is nothing but it is caused because of the alteration in the metabolism. It also depends on the quality of the ahara. Quality means what? If the person is every day taking curd and curd and curd, or too much unctuous food, or very dry food, very heavy food, or the food which is producing burning sensation in a body, or any drinks which is producing burning sensation in the GI tract, of course, it is not good for the health. Then processing of the food, whether it is correct or not. Like if the person is taking uncooked food for prolonged period of time, or the patient is taking very maida items like starchy food, he's taking that whatever food which is prepared with maida, or he's keep on taking the lays or kurkures or fried paddy things, it will create a problem in metabolism. Contaminated food, they are talking about one of the causes, contaminated food, that means spoiled food and stale food, shira anna. Then again, another point is like the food which is increasing the pitta in a body, like overeating. Some people do not understand it where to stop while eating. Some people keep on eating even though they are having indigestion. Some people will take excess of acidic food, like they will take different types of Pepsi, cola, or that soya sauce or tamarind juice. Some people are very fond of taking the incompatible foods, the combination which should not be taken togetherly. Some people will keep on taking very thick items, or whatever, drinks also and food also. So that is again a cause of pitta prakopa. Then one of the causative factor, again, they are told like the food which will create weakness of your digestion. That is excessive fatty diet, excessive dry diet. That is also one of the cause. Secondary thing, they are told that faulty dietary habits. That means what? If you're taking untimely eating your food, that is in the mid of the night, you're getting up and you're taking your food. After 2 hours, if you're taking the coffee, after 2 hours, again, you're taking some other drinks. Actually, this is untimely eating. Okay. And you're not taking your meal in a proper time. So this is also the faulty dietary habit, which is again the positive factor for the Amla Pitta. And of course, like taking alcohol or alcohol consumptions, empty stomach alcohol especially, and the milk products. These are also the causes told specifically for the Amla Pitta, which we see that it is like burning issue of the present era because of the food we are not taking in a proper manner. Another causative factor for Amla Pitta is lifestyle changes. That is doing excessive physical work. They are like around the clock, they are doing the physical work, or lack of physical work. That is, they will not at all lift up their body. Then fasting for longer period of time, sleep deprivation, holding natural urges, and daytime sleeping. Okay, all these things will lead to what? Pitta aggravation, ultimately lead to what? Amla Pitta. Another thing is like external causes. Consumption, as I told you, consumption of smoking, hair, tobacco, then beverages, some sort of another toxic substances and alcohol, again causing irritation of the stomach, causing Amla Pitta. Psychological factor also. Psychological factor, it consists of stress, anxiety, psychological factors, lots of paper published on this, showing that it disturbs the Pitta and it contributes to the formation of the Amla Pitta. Another factor is like lots of the people keep on taking the different types of NSAIDs and corticosteroids, different types of the medicines, which again creates the like increase the Pitta dosha in the GI tract and causing the problem. Some of the season also, for example, like in October heat, automatically the Pitta is increased, and which is also the causative factor for what? For the Amla Pitta. Now the diagnostic tool. When we talk about diagnostic tool, so actually it is depending upon the signs and symptoms my patient is having. So what are the general signs and symptoms we'll see? It is like indigestion. What your patient will first tell you, it is indigestion, then feeling fatigued. That is doing nothing also he is feeling fatigued. Nausea or sore belching or heaviness or rutkantadaha, that means burning sensation in the chest and loss of taste. If we talk upon, am I audible properly? Yeah, I'm audible properly. Yes. Yeah. If we talk upon the how to diagnose, in this also it is given that there is Vatadikya Amla Pitta, there is Kaphadikya Amla Pitta. The symptoms will be same. But if the patient is talking about, I'm feeling tremor, in between I'm having the body pain, I'm having dizziness, confusion, restlessness, as a suya tochल्यासारख्या वाटतायत, and all these things that the patient is telling you, you have to understand that this is Vatadikya Amla Pitta. It is Amla Pitta, but which dosha is increased? Vata. And if the patient is telling you that I'm feeling very much heavy in the body, I'm feeling cold, I'm feeling vomiting, I'm feeling sleepy. Every time I feel sleepy, my salivation is increased, I feel like spitting every time, all this thing, lack of appetite and all, then you have to understand that this is Amla Pitta, but it is Kaphadikya. Sometimes there are mixed features, mixed symptoms also. Okay. So these are our diagnostic tools, mainly the signs and symptoms, what the patient is telling. And very important thing is like another tool is which type of the Amla Pitta. The general symptoms will be same, but if the doshas are coming out, patient is telling ki mala toilet la javasa vattay, then it is adhog Amla Pitta. That is doshas are trying to come outside from the adhobhaga. And the patient is feeling that I'm feeling like vomiting. That means what? It is dosha utklesha. Doshas are trying to come outside from the mouth itself. So it is urdhva Amla Pitta. Then I think the doctor which have presented the case, it will be coming under the urdhva Amla Pitta and Kaphadikya Amla Pitta. Now, if we see very quickly what is the pathogenesis, yeah, of course, it is caused because of the altered metabolism, which is because of the causative factor like aharaj, viharaj, means because of the wrong food they are eating, wrong lifestyle, then the stress they are not able to handle by themselves, and in addition to it, addictions. These are all the causative factor for it, which is creating vitiation of the pitta component in the body, which is very important for the metabolism purpose, and it will create the vidagdha avastha of the ahara, create the arm, which is visha, and then it will, to which we call it as arma visha. Again, the soreness is very much increased, and to which we call it as the amla pitta. And this is very dangerous condition because it will keep on moving through the micro channels all over the body. Treatment part. If we talk about the treatment part, very important thing is we have to understand whether the condition, symptoms are mild, moderate, or severe. If it is mild, then we have to tell the patient that patient is telling you ki तुरीचं वरण खाल्लं ki I get acidity. Then you have to tell your patient that avoid the causative factor responsible for Amla Pitta. If the patient is telling you ki I'm avoiding, but then also I'm feeling the same problem, then there is a step that you have to start with the internal medicines. Internal medicines which will pacify the vitiated doshas. Okay. So internal medicines like you can, depending upon the dosha avastha, you can give Mahatikta Kashayam or Abu Nimbadi Kada or Kamaduda if it is related with stress, or Lagu Suchikar, Sada Suchikar, Avipatti Churna. There are, depending upon the condition, we can give this and patient feels better. Okay, patient feel better if patient is having mild to moderate vitiation of the Pitta. But if at all you are giving the medicine and patient is not at all feeling better, then that is a Bahudosha Avastha, and it is a time for detoxification of the body. And if there is Kaphadikya, you have to go for Vamana, you have to go for Panchakarma. If there is Pittadikya, you have to go for Virechana. And if at all there is the Vatadikya, you have to go for the Basti as well. So depending on the Bahudosha Avastha, you have to go for the Panchakarma also. So what are the limitations for this topic? Limitation is like patient's compliance with diet and lifestyle changes becomes very difficult. Majority of the patients, see if at all a patient is IITN and he has a work that he'll work only in the night time, for him to follow the diet and lifestyle changes become very difficult. If the patient is security guard, or if there are students who complete their assignment only after burning their lights in the night time. So for them, it becomes very difficult to follow this diet and lifestyle changes. So this is one of the factor what I feel has to be taken into consideration. Severe complications actually needs the allopathic interventions like bleeding. If at all some patients are telling ki मला उलटीमध्ये रक्त दिसत आहे किंवा मला bleeding होत आहे किंवा मग काळी काळी शी झाली, so that is a concern point. Barrett's esophagus also one of the complications. Then I have to refer the patient or take the allopathic opinion also, or difficulty in diagnosing complicated cases like in advanced stages of amlopitta, that is hiatal hernia, then Zest syndrome, we can say excess acid production. For the clear picture, we have to take help of the modern diagnosis tool like endoscopy and biopsy. Then some of the contraindications in the emergency conditions, like for example, the patient is having severe vomiting, he is having hematemesis or extreme acid reflux. By any means that vomiting is not stopping, all these things, then actually I have to take, there is a limitation point here. I have to take the emergency, necessary emergency care also. And dependence on the physician expertise. If at all my patient is living in the remote area, to reach towards the physicians who are very expert in this dome, so they have to travel so much of distance. So that is also one of the limitations we can see, and limited scientific validation. In our science, actually, this GI tract, this thing, GERD, is very nicely treated. We have treated lots of people, but then a proper documentation where the reporting has been done. Only the physician or the practitioner knows that हे बरं होऊन जातं, काही आयुर्वेदिक औषध घेतलं तर. But where is it reported? It is not published anywhere. When thousands of papers are published, then we can extract a very good essence from it and we can come to the conclusion. But this is also one of the scientific validation. I can say it is one of the limitations. Okay, it has to be taken care of by us only, by the practitioners only. Now, what are the referrals? What I feel is like immediate referrals I should understand, and routine referrals also I should understand. Vomiting of the blood. If the patient is vomiting and there is the blood in the vomitus, of course, there might be upper GI bleeding or peptic ulcer or malignancy, then I have to refer at least to the gastroenterologist. If there is severe dehydration, I'm not able to manage it on my medicines itself, then of course I have to, for the electrolyte imbalance or there is the shock, I have to refer them to the general physician. If there is severe epigastric pain, which is not relieved by my attempts also, then also like I have to keep in mind that it might be peptic ulcers or gastric perforation, pancreatitis, I have to refer to gastroenterologist. If there is melena, black tarry stool is there, yeah, of course it is upper GI bleeding, it is assumed, and I have to refer to the specialist. If there is sudden severe abdominal pain along with the fever itself, there might be perforation or peritonitis. I have to, that is an emergency condition, I have to refer. Uncontrolled persistent vomiting. Okay, the risk of dehydration, electrolyte imbalance, I have to refer. I should understand this is the immediate referrals. I have to refer to the specialist itself. Okay. Then what are the routine referral? Routine referral is like progressive weight loss. If my patient is having progressive weight loss, appetite loss, then there is suspected malignancy. Then yeah, of course, I can refer to oncologist for taking his opinion. And if even though I'm giving the Ayurvedic treatment, patient is not feeling good, okay, then yeah, of course, I have to rule out by H. pylori GERD or ulcers. Taking opinion of gastroenterologist will be on the safer side. Then suspected Zollinger-Ellison syndrome, okay, gastrointestinal tumors. Yeah, of course, I have to take the opinion of gastroenterologist before treating my patient, or combinedly we can treat the patient. Or stress or anxiety is another important factor. By giving our medicines, if the anxiety is not been solved, then for his mental health management of my patient, I have to take help of my psychiatrist also. Then recurrent heartburn, difficult swallowing, dysphagia we can call it as. So Barrett's esophagus, esophageal strictures, yeah, all these things I have to keep in mind, that these are the things which I have to do. That is a routine referral. Okay. The only ultimate aim should be like when patient is coming to us, so we have to treat him wherever necessary. Allopathic diagnosis investigation, it is important only. And in some cases we can give the parallel line of treatment also. That means the specialist can give their treatment, and at the same time we also can give the same treatment. Ultimate motto is like giving relief to the patient. Okay, it's not the pathy which is here, it is like giving relief to the patient. So what I feel is we can do in that way also. So these are the things. And thank you so much for the patience listening. Thank you so much.
Thank you. Thank you so much, Dr. Megha. You have given us detailed knowledge about ahar, vihar, and vichar in etiological factors. Then discuss investigations or how to diagnose amla pitta. Then treatment part, and then limitations. And very well said that there are limited scientific publications in Ayurveda literature, and we have go forward in that direction. Thank you so much. Now, we have Dr. Manisha Shinde to discuss homeopathy. Please present your, yeah, I will show you a PPT. Wait, have your PPT. Is it visible?
Yes.
Okay. Please start.
Okay. Good afternoon, everybody. Myself, Dr. Manisha Shinde. Thank you very much, Gitanjali Karle ma'am and Ayush department for giving me this opportunity to talk about some homeopathic approach toward the case. The case of GERD, that is gastroesophageal reflux. And Dr. Pratibha and Megha had already done a lot of discussion on that. So I will discuss in short, but I will focus on the homeopathic approach only. Because already both have discussed about what is the pathophysiology mechanism, and Megha ma'am had also talked, though I am not knowing Ayurveda in detail, but I got the PPT very well. Very studied approach was there. So I like that approach. And symptoms already, causes and symptoms we have gone through, but just as in short, we will go from the, this is the definition, just we had seen, we had discussed about the, it is a chronic condition caused by the prolonged reflux of a gastric content into esophagus. And this is the diagram which shows whatever the pathophysiology in the stomach. And causes, next, causes of GERD, hiatal hernia, obesity, overeating, drinking certain beverages like soda, coffee, and cold drinks, eating spicy, fatty, or acidic food, smoking, taking certain medications like aspirin, antidepressant, and most important cause is night watching. Though our patient is has that cause, and prolonged taking of the spicy and fatty food. Then clinical feature, just both had discussed, so we will skip this slide because again saying the same thing. I will focus on these homeopathy acts. So homeopathy is a system which based on the similia similibus curantur, which means like cures like. So in case of homeopathy, there is a this is the total general approach of any case. We have to go through these steps to solve the case and for the diagnosis and for further treatment. So this is just a modus operandi of homeopathy. So first, homeopathy stimulates the vital force. It stimulates the natural energy of the body to fight against the disease. And that like cures like means the symptoms, same symptoms which drug has, we give that drug and we have a cure in the patient. Then holistic action. Holistic action means holistic approach treats the disease as a dynamic disturbances, not just the physical pathology, because we consider any pathology in the body has the mental origin. That's why we focus on the individual, whatever the lifestyle, whatever the mental condition of the patient, we focus more on that and then we will proceed the case. And homeopathy has dynamic effects, work through energy, not chemical suppression. We stimulate the natural energy inside the body. And individualized approach. Individualized approach means every person is a different and unique. So we have different types of medicines for the same diagnosis of the patient. Means the same medicine cannot given to another person because he has his another, just like Vat, Pitta and Kapha in Ayurveda. Everybody has different tendency towards the physical secretions. That's why we have three miasms, that is Psora, syphilis and psychosis. On the basis of that, we have individual approach of the every person. And homeopathic system is very gentle and safe, non-toxic and suitable for all age groups. Chronic and acute case acts quickly in acute cases, acute issues, and deeply in chronic conditions. Then minimum dose, smallest dose stimulates healing while avoiding the side effects. Potentization remedies are diluted and suctioned to enhance the healing power and removes the toxicity. That's why we don't need any crude form of medicine. We use the potentized form of medicines, which are very safe and acts dynamically. Then single remedy, only one remedy is given at a time to match the totality of the symptom. As we have seen in this case, we have 4 to 5 symptoms and we will collect those 5 symptoms and we will see the totality of symptom for the correct medicine. Then Hering's law of cure. We follow the law, that is healing proceeds from Hering's law of cure means from inside out, from top to bottom, and in reverse direction or in reverse order of the symptom appearance. This is the Hering law we follow when cure is taken place. Then miasmatic theory, which I told you that Psora, syphilis and psychosis, these three miasm, and this GERD is a psychosyphilitic miasm, means loosening of the gastric entrance. So now regarding our case, which the student had discussed earlier. So these are list of symptoms. The patient have heartburn, regurgitation of acid, headache, rash all over body, nausea and vomiting, dysphagia and chronic constipation. So case management, we will consider these set of symptoms to select the medicine. So we will select medicine, but along with medicine selection, we will advise patient for this lifestyle and diet recommendation. Well, ma'am had already, Megha madam had explained very in details. So I will tell in short, encourage high fiber diet and adequate hydration. Avoid trigger food such as outside packed food, spicy or greasy meals. Follow proper nutritious diet plan. If the patient can focus on the health, so if she follow the diet plan properly, hourly, and with proper nutritious content, I think she will definitely relieve. And most important part, though I had discussed earlier that we consider the mental condition of the patient and stress and all that. So for that, stress management techniques patient should go through, that is yoga and meditation, which is just I want to add in Mega Ma'am's plan. Then our homeopathic etiology. Homeopathic etiology means some main causes of GERD are mental cause like anger, anxiety, depression, stress, and long continued grief. Means whenever patient thinks a lot, gets stressed, the acid secretion increases in the stomach. And that stomach causes erosions in the system and the esophageal reflux there. So as per case, we have got the total in terms. I have 3 probable remedies, that is antimicrobial, sulfur, and lycopodium. These 3 are the remedies, but to go through the detail with the case in other ways, a homeopathic approach. But these are 3 drugs which will relieve the skin rashes also, that reflux mechanism, reflux serum, water the patient have had and burning sensation. Then these are some remedies of homeopathic remedies which mostly indicated a lot of cases which I have cured acid reflux, and simple acidity also. So these are common remedies that are carbomate, china, arsenical, and phosphorus. These all remedies have burning sensation in the chest, but as per the background of case history, patient has, according to that, we give only one medicine according to the modalities of the person, the patient, and whatever the background of the patient. So this is the commonly indicated remedies. And we have the most important limitation is only surgical cases that there is a total loss of finger or there is a total prolapse of the gastric. In that surgical cases, homeopathic management has limitations for that. Thank you.
Okay, thank you so much, ma'am. I think homeopathic etiology is wondering more around mental causes and will explain etiological factors and treatment. Thank you so much, ma'am. Now, is there any query from participants? Dr. Meenal? Dr. Meenal,
Yes, ma'am.
do you have any query regarding your case?
No, ma'am.
Okay, then we will stop here. Thanks to Dr. Meenal Gupta. Thanks to Dr. Pratibha Sonone, Dr. Megha Sarose, Dr. Manisha Shinde. Thank you so much. Audience, thanks.
Thank you. Thank you so much.
And one thing more, there is feedback form. Link is there in chat box. Please fill and send us your feedback. Your feedback is valuable for us. Thank you.
Thank you so much.
Okay, thank you, ma'am.
Thank you, ma'am.
Thank you all.
Thank you.